All right. Hello, everyone. Happy Thursday. Welcome to VMR. We have to start with the reality that a team member is joining us at 3 a.m. Our beloved Aaron is scribing today. Let me hand the mic to you to say hello.
Morning, everyone. It's Aaron. It's currently 3 a.m. in Hawaii, but I enjoy waking up on these Thursdays to hear Robbie discuss with one of our members and just excited for Manaswini's case today.
Thank you, Aaron. That's very, very kind. Halfway across the world, almost literally, is Sakit, who's doing teaching points in India. Mic to you, Sakit.
Hey everyone, I'm Saket. I always learn so much from Eugene's discussion, so really excited for this discussion today.
And I'm excited to say that, that I get to discuss with Eugene for the second time now. I think it's a little bit bittersweet. I'll share why at the end, because it's a very powerful moment in his career. He's really been such a gem in the realm of CPS cases, the realm of the CPS world, I should say. Yeah, we've known each other for a year. I still vividly remember our first conversation where Eugene's enthusiasm was bursting through my car. So I was driving back from Los Angeles to San Francisco, and I could just see how enthusiastic and creative this human being was. And uh, over the last year or so, we've gotten to know his home, his car, gotten to meet his life partner, and and much, much more. So very, very excited to share the space with you, Eugene. I'll hand the mic to you to say hello, and then we'll introduce our case presenter.
Yeah, thank you so much, Dr. Rafi. A lot of kind words, but I think it's just evidence of how you have been able to craft this space for all of us to be comfortable, come here, hang out, have fun, and enrich ourselves with a lot of medical knowledge. Also, how to actually manage patients in real life. So, you're a great mentor. Everybody here can attest to that. And so I'm always excited to be in a space with you, discuss with you, and also have been very key in some of the successes that I've had in my life, my recent match, how I've become quite. I know I've changed drastically in terms of my way of managing patients over the year, so it's amazing, and I really appreciate you so much.
Yeah, I was going to share that wonderful piece of news, and actually, it's a piece of news that unites everyone here, with the exception of Aaron, who's applying next year. Sakith matched, you matched, and our outstanding case presenter Manaswini is also matched. So it's, I think, the first time that all three of you are gathered in this space, and I think all three of you are very, very humble about that. Yeah, I'm thrilled to discuss with you, and I'm thrilled that it's a case from Manaswini. I'll hand the mic to you, Manaswini, to say hello.
Hi everyone, I'm Manishwarni. I echo everything Eugene just said. So excited to be here and present the case to Dr. Avi and Eugene. So excited for the discussion. Yeah.
Yeah, I imagine I won't be seeing you tomorrow at 9 a.m. Pacific time during the VMR. You'll be getting some really exciting news. So I'm gonna enjoy the hour that we get together and hand the mic to you, Anna Sweeney, to kick us off.
Thank you. So this case has 5 aliquots, with the sixth one revealing the diagnosis. So here goes the first aliquot. It's a There's a 29-year-old gentleman who walks into the hospital for the first time with a blood pressure of 60 over 40 mmHg, and it was confirmed on repeated measurements. And he also has a very rapid and a thready pulse, and that's the first aliquot.
Lyra, it was really funny to see the expression on your face when that blood pressure came out. I'm sure Eugene was feeling something very similar. What are you thinking, Eugene?
Yeah, I mean,
Oh no.
somebody. Oh, you can hear me?
I think your voice, either mine or yours, chopped out.
Can you hear me clearly?
Yeah, we can hear you now. Yeah.
Yeah, so I would say that the first thing that is surprising to me in this case is the fact that BP of 60/40, and this patient was said to have walked into the. you have BP of 60/40, that's hypotension. There are just some areas of the human system that you can start thinking about, and the first is the cardiac area. So you're wondering if this is as a result of some underlying pump issue. Is this patient not, having some cardiomyopathy, but for an age of 29 years, you may not think about that. Also, you'll be wondering if, because they mentioned that this pulse is rapid and thready, is there some form of arrhythmia and with conduction issues, which is also manifesting in the peripheral sites as hypotension? But you can also consider other issues like if this patient just through examination, other vitals, you notice that this patient was also extremely febrile, is having acute inflammatory signs. You may think this patient is septic because sepsis can lead to this level of hypertension. Another area that you can consider is neurogenic. Is there some form of irritation to the vagal nerve, and so that is leading to, but usually that will lead to rapid drop in pulse and then dilation of the vessel, and could also lead to the symptom of hypertension. But this time we're seeing rapid and thready. Another area that you could consider is volume. So volume could be one major area whereby you're wondering this patient has had acute blood loss and is manifesting in hypotension. And so that will also lead to the rapid pulse rates, which could be thready. So these are some of the things that I would be considering going forward. It was already said, I'm not sure if it's not right or correct, because I'm still wondering somebody walking in with especially diastolics of 40. So that's very important to do. I'll still repeat it again and then make sure that is accurate. And then rapidly, such a patient needs fluids. They will need IV fluids immediately to sustain them. And then if IV fluids are not sustaining, then you could start thinking about the endocrine issues, so adrenal insufficiency. Then you could look for other signs in the examination on the skin, and then also in the labs that can buttress adrenal insufficiency. Want to also quickly give hydrocortisone in that situation to just save the patient. So yeah, I believe you could streamline more stuff to add to this, but these are my thoughts areas. So cardiac, volume issue, blood-borne issues, endocrine issues can all lead to this particular presentation.
Eugene, as you can imagine, how could I possibly have any advice for you after you shared such a thorough and precise approach to hypotension? You have really piqued the idea of what it is to be somebody who is about to jump into the trenches of residency. And what you have learned so far is to develop such a comprehensive and practical approach. And I think what intern year will teach you, almost frustratingly so, is that it is impossible to hold all these thoughts that you just had in the single snapshot moment. And so it becomes a little bit of an exercise to say, not what should I add, but how can I put pieces in order? So instead of thinking about things like this, right, which medical training has taught you so far, what you have to do is counterintuitive, is you have to think of things like this. And what do I mean by that is you only see one thing in front of you right now, but everything is walking in a straight line. So instead of being washed by a tremendous amount of hypotheses, you have to reorient your field and see them not as 10,000 things at the same time, but one thing after the other. And so in a case like this, I think what I would do is I would make sure the patient doesn't walk again. No more walking. The problem with walking is that the blood is going to the muscle. And right now, I don't think we have enough blood to spare. You might also say, no more walking, and let's put you in Trendelenburg so we can get all the blood to Manaswini's favorite organ, the brain. I don't know if that's true, but I think it's true. Um, those are the most important things. And then we now know, as you said, that there is a widespread problem, right? Every part of the patient's body is being underperfused. At least that's what we think we know. What we really know is that probably the patient's left arm or right arm is underperfused because we measured the pressure in that arm. And the question is the patient fully underperfused, and does that arm actually correlate with his body? And in most instances, you don't have enough time to sit there and be like, I wonder if... No, you got to go. But you should always remember what assumptions you're making. Because he easily could be just fine and has subclavian stenosis on the side that the blood pressure is being measured. And his brain blood pressure, muscle blood pressure is fantastic. But that is not something you want to stop. Even if you turn out to be right, and that was correct, you still have to first assume straight thought. This is a little branch that you can't hop off now. And so the question becomes, in somebody who presumably has a diffuse problem, is exactly what you said. Where did this problem start? Because all hypotension starts in one specific location and then spreads. An MI right here. A pneumothorax right here. Spread. An infection in the urine. Spread. A hemorrhage in the adrenal gland. Spread. There is no such thing as a primarily diffuse cause of hypotension. All of hypotension is either a focal problem in a very strategically bad place, like the pulmonary artery. Focal, that's it. Focal and bad location. Or it is a focal problem that secondarily generalizes. Focal pneumonia, sepsis. Focal adrenal disease, hypotension. So the question in a patient with hypotension immediately becomes, let the patient guide me to where this began. Because I know likely it's diffuse, but if I just use my ears and say, I got a bee sting, doc, and now, I have a cough, doc, I have urinary issues, I have flank pain, or the sneakiest of all is when you don't have a secondarily diffuse problem from a focal issue, but you have a deadly focal issue in a very, very bad place, pericardium, PE. Those are the hardest because those strategic focal places often are very subtle. It's hard to see them, and the patients don't notice them either. So I'm right there with you. Everything that you just said is captured in the sense that first, treat, remember the assumption you're making, and then go on the search for where this began. All hypotension begins in one location and then spreads. So let's see what Manaswini tells us about where this began.
Awesome. So let's start where it all began. So the patient's main chief concern was that he had acute onset chest pain, palpitations, and fatigue that started 20 minutes prior to the arrival. He described his chest pain as something that began suddenly while he was vacuuming the sofas, which is something that he usually does as a part of his routine household work. And he described this pain as a pressure-like associated with a lot of discomfort, accompanied by some rapid pounding heartbeat with fatigue and mild dizziness. But he did not experience any syncope. He had no prior episodes of similar symptoms in the past, and he said that the pain was not being relieved on rest. So he had no headaches, no edema. He worked as a domestic worker and the member of a family who he worked for brought him to the hospital as they were really concerned. No past medical history. And when we checked vitals, it was 60 over 40, saturating at 97% on room air, and a heart rate, which I will show the EKG for, and a very rapid and thready pulse, and a respiratory rate of 22. But he was conscious, alert, and oriented. He could answer his name, where he was, who the president was. And on exam, he had his S1, S2 was normal and no murmurs. Abdomen and pulmonary exam normal, and extremities were warm. No edema or rash was seen. His blood was drawn and the EKG was done, and this is what the EKG showed.
Just have to say, Manaswini, your ability to present cases is unreal. I feel like we're right there at the bedside. You bring the case. I can already see a book 10 years from now. Manaswini, come join me in my real life clinical care. This is unreal. Thank you. All right, Eugene, I bought you some time. I wonder what your I wonder what your heart rate is now, but take it away, my friend.
Yeah, I mean, so you taught us to first just take a snapshot of what we are seeing and then just comment on the general picture before then we look at the nitty-gritty. So just just looking at it, the heart rate is super fast. I mean, this is an abnormal rhythm. And I can quickly just say probably this patient is having some form of ventricular tachycardia. As to why, now we need to go back to the early presentation from the history of presenting complaints,
I
then
always hate to
examination.
interrupt you, Eugene, but can I ask you a favor? Because I think many people listening to this may not have the abilities that you did to say this for tachycardia. So can you explain how you came to that conclusion for your juniors?
Yeah, so tachycardia, because if you look at the various small boxes in between the KRS complexes, it's just about one box in between, so meaning the heart rate is very fast. Then it's wide complex, so that is something that you can use to support the idea of ventricular tachycardia, and you can still see some P waves. So you could, I mean, you know that there is some form of rhythm originating from the sinus node, and then it's being conducted through. So, I mean, that's how I piece it together. And also from memory, that's I've seen similar pictures like this, so I just can
Good.
comment on that.
Very good. Yeah, I know you are already thinking about the next stage, which is why is this happening? Let me just take a brief moment to reinforce the EKG teaching, and then I'll hand the mic back to you to then speculate on why this is happening. Does that sound okay? Yeah, I think you taught us the very fundamentals of this EKG, and I think what we're seeing here is a rapid wide complex tachycardia. And a rapid wide complex tachycardia um, means fundamentally that the conduction in the ventricles is happening slowly from myocyte to myocyte to myocyte. And the highway that would ordinarily be used to bypass cell to cell conduction, the His-Purkinje system, is not being used. And there's two reasons for that, and quite simply. The first is it's not being used because there is a focus of abnormal activity in the ventricles that is generating the impulse, and that abnormal activity is originating outside the His-Purkinje system. So the His-Purkinje system is fine. There is just an invader in the ventricle somewhere else doing its own thing. The other possibility, of course, is the His-Purkinje system is not fine, that it is diseased. And so what we're trying to tease out is the underlying health of the His-Purkinje system. Is it diseased or is it healthy? And I think the pretest probability of an unhealthy His-Purkinje system in a patient who is 29 is pretty unusual. The problem is that it's also pretty unusual to get a ventricular tachycardia in a patient who's 29. So the base rate here is actually a little bit tricky to ask yourself what's more common. In sum total, supraventricular tachycardias are way more common than ventricular tachycardias in young people. However, the necessary supraventricular tachycardia to induce this EKG requires an unhealthy or a bypassed his Purkinje system. So the only supraventricular tachycardia that is plausible here based on base rate is AVRT, AV node reentrant tachycardia, where you have antidromic. This is complicated, but basically, if you have an accessory pathway, as would be the case in a patient with Wolff Parkinson White, what could happen is that you can actually conduct up the accessory pathway, not down, and induce a wide complex tachycardia with the origination being in the AV node. That's the only realistic benign possibility. Apart from that, this is VT until proven otherwise. And how you can really essentially prove that it is VT are the things called the Brugada criteria. And there are many things that go into the Brugada criteria, including concordance. So the idea being that if the QRS is pointing in the exact same direction in V1 through V6, that's very, very concerning. So here, actually, you do meet criteria for concordance because V1, V2, V3, V4, V5, and V6 are all pointing in the same direction downwards. So that is a very, very powerful tip-off that this is ventricular tachycardia. The other clue is that the axis is very much ventricular in origin. So you see, for example, that it's positive in AVR. Positivity in AVR means the impulse is going from the bottom of the chest up to the top. That is very suggestive of a ventricular focus. Unfortunately, what would be diagnostic of VT with almost no holes is when you see the patient having fusion or capture beats. What those mean are intermittent conduction from above. So if you see a fusion beat, which is a combination of a large and a small beat, or a capture beat, which is a small beat, that tells you that the His-Purkinje system is healthy and that all these other beats are actually not from an unhealthy His-Purkinje system. So I don't see any of those here, but the absence of those doesn't really mitigate against a diagnosis of ventricular tachycardia. The last thing you look for, Eugene, is what's called the R to S height, which is how high, what the difference is between the R and the S. And these are long things, but unfortunately here there is no R wave. These are all just pure S waves. So I'm unable to use the R to S height. So in summary, when you see a wide complex tachycardia like this, your default diagnosis should be ventricular tachycardia, and then ask yourself, could this be SVT with aberrancy? Aberrancy would be very, very unusual because it would mean that a 29-year-old has conduction system disease, very, very rare. The only possibility, realistically speaking, that is not uncommon in young people is an accessory pathway conducting in an unusual way, and so this would be uh, um, the alternative possibility. But realistically speaking, Eugene, I think we now have to manage the patient before we think about what is going on. So I'm curious, how do you think you would manage somebody like him?
Um, yeah, so I think the important thing here is to try to correct the arrhythmia.
Yes.
But so in my thinking, I'm just wondering what can we give to kind of like slow this heart down?
Yeah.
So can we give some form of just wondering, can we give some form of maybe a beta blocker? Like but I'm not sure if that is correct. I'm just saying what I'm thinking. So so can we give some form of beta blocker here? So maybe like maybe F's. I don't know. I'm not sure, but just so what I know is we need to try to get this rhythm to be normal.
Yeah.
But whether we should do a beta blocker or a amiodarone, I'm not so sure what we should do.
Let me
Yeah.
just ask you one question. How much time do how much time do you want to fix this arrhythmia in?
I don't get it.
Maybe you can mute real quick and then yeah. Do you mind? Yeah, okay. How much time do you want to fix this arrhythmia in? Few hours, few minutes, few seconds. What do you think?
I think few minutes, you should,
Yeah,
in
exactly.
seconds, you should be able to
Yeah,
fix this.
exactly. There's only one option when you want to fix something that fast. And I think when you're trying to understand how to fix arrhythmias, there's three options. When somebody is pulseless from an arrhythmia, you only have one option. You do an unsynchronized cardioversion or unsynchronized shock. You don't have time to do anything but just hit a button. That's it. One button. Shock. The other option on the complete other spectrum is the patient is very stable. And so then you can give the patient medications that can take some time. If somebody is not pulseless, but also not stable, you have time to do a shock, but a fancy shock. And that fancy shock is called a synchronized cardioversion. And you have to press two buttons. First button you press is sync, which allows the machine to time its delivery on top of the QRS. This avoids shocking at other parts of the cycle, which can actually have paradoxical consequences. So, arrhythmia, stable, use your brain, take your time. Pulseless, press one button, shock. Peri-pulseless, unstable, press two buttons, synchronize, and then shock. So my simple teaching, you see this EKG, you look at the patient, they're not pulseless, but they're not very stable. Press two buttons and don't do anything else. Okay? And then we can speculate on the cause and whatnot. But in real life, nobody's thinking about is this Brugada? Everybody's thinking, wipe my sweat with a towel and synchronize this patient. So Manaswini, I'm curious what this felt like for you and what you all did.
Yeah, it was an adrenaline rush for sure. And coming to the next aliquot, so I have nothing to add after the wonderful discussion. But so the EKG showed monomorphic wide QRS tachycardia, like you mentioned, and with concordant negative waves from V1 to V6, suggestive of ventricular tachycardia, and associated AVR positivity. So the first thing that the emergency team did, I was not at the emergency at that time, so they gave them amiodarone 150 slow IV for over 10 minutes, and the patient did not revert, but he was still conscious, lying on the bed, and he had a pulse, but his blood pressure was still super low. Then, after a couple minutes, they loaded him again with 300 milligram amiodarone slow IV over 10 minutes, but he was still hypotensive, 66/42. And then, like Dr. Rabih mentioned, unstable but still a pulse, two buttons. So they sedated him and performed a synchronized cardioversion of 100 joules. And he reverted back to sinus rhythm with over 100 beats per minute, and he was shifted to the ICU. There was 10 minutes of calm that passed when suddenly the monitor jumped to life again, and it was another episode of ventricular tachycardia demanding intervention. So he was cardioverted again, and lignocaine of 80 mg was given. The team was really worried, so they started him on 3 liters of oxygen. And he was in sinus, and there was calm for 5 more minutes. And yet again, there was another episode of VT. So he was cardioverted, and metoprolol of 1 milligram injection was given, after which he did not have any recurrence of VT for some time. So the blood pressure improved to 90/56. He's still saturating at 98% and a heart rate of 100 beats per minute. So owing to the low BP that was not improving and the 3 cardioversions that were given, he was started on noradrenaline, 80 ml per hour, 2 ampules in 50 mg NS. And in the meantime, the labs came back So the hemoglobin was normal, WBC is normal, the electrolytes potassium 4.2, magnesium 2, calcium 9.6, troponin normal, and chest x-ray was normal, and a bedside echo was done where RA and RV showed dilatation with some RV wall motion abnormalities, and the LA was normal. He always had a pulse at all times. So to summarize, he had 2 doses of amiodarone, 1 dose lignocaine, 1 dose metoprolol, cardioverted thrice, and was on norepinephrine. So he was stable at this point. Would love to hear your thoughts.
I'm just in awe of this presentation. I don't think we've had anything like this on VMR. This is really, really unique. Eugene, I'll guarantee you one thing about your intern year, no matter where you are, is your first patient will not be as sick as this one. So you're getting much more intensive practice. Yeah, let me hand the mic to you to see what thoughts you have.
Yeah, quite interesting. So, we seem to have a young patient who has had ventricular tachycardia. We don't yet know the underlying situation why this happened, and has had multiple shocks and medication, reverts, and then gets back into that state. So far, the usual things that can be done, because usually you associate ventricular tachycardia with acute coronary syndrome. We've done troponins, which was normal, and the EKG when this patient was sinus didn't really show any ST changes, T-wave inversion, so we can be sure that it's from an infarct. But there are other situations, congenital abnormalities that can lead to this ventricular tachycardia that we've not yet investigated. Also, electrolytes abnormalities that can lead to that, which is not yet investigated. I've still not seen any reason for this high sympathetic, this high rush of adrenaline that is causing this patient's tachycardia. So we need to still do some other investigations. The echocardiography shows right atrial and right ventricular dilatation, and then wall abnormalities. So now I'm wondering if there is something happening in, so when you have right atrial dilatation, could it be a consequence of what we are experiencing? That's the ventricular tachycardia, or could it be, if typically this patient was older, then you'd be thinking of some lung problems, fibrosis, congestion, or hypertension in the pulmonary arteries that could now be inferred in the right atrium and right ventricle. So I would still want to do some more investigations to repeat the ECG. This patient is already in ICU, so look at the telemetry and look at the ECG when this patient is in sinus rhythm and try to see if we can be able to find out whether the QT is prolonged, whether to try to pin it on a long QT interval that is leading to probably, or try to see if this Bogarda syndrome. So those are congenital channelopathies. Then also you want to do some electrolytes. I think we've done potassium, which was normal. Okay, so electrolytes have been done, which are all normal. So we can take out electrolytes. And I think we can also do some maybe a CT, a cardiac MRI. I don't know if we can do a cardiac MRI in this situation to see if there is some issues with the muscle itself. Because echo did not really tell us about the septum, whether there are issues with the septum bulging into the left ventricle. So I can't really get a sense of direction until I do some extra labs. So I want to still see a proper ECG when this patient is in sinus rhythm, and then also probably repeat the electrolytes, get a trend of it, and then thinking about advanced imaging like a cardiac MRI.
Yeah, I think your reflections are very well founded, and I will just take a few minutes um, to really try to explain this space as best as I know it, because I think it can be a little bit overwhelming. I think it's helpful just to start with the realization that the electrical activity here is the consequence of an underlying issue. And it's such a life-threatening consequence that managing it and temporizing it takes initial focus. And if the consequence is a ventricular tachycardia, the tools in your armamentarium to empirically treat it, defined as treating it without caring what the underlying issue is, are a bunch of antiarrhythmics, starting with amiodarone and lidocaine, including other ones, blind shocking, agnostic to the underlying cause, and then specifically for ventricular tachycardias, realizing that sympathetic tone is a big, big contributor to the generation of that electrical activity. So if you're thinking about how do I empirically treat, and again, empirically is defined as treating a condition without regard to the underlying cause because it's a serious one, is antiarrhythmics, shocking, and sympathetic tone modulation. And I think this case is so interesting that we won't have enough time to fine tune what sequence we go in and whatnot in terms of the empiric strategy. And I think Manaswini is demonstrating that by showing us MEO, lidocaine, beta blocker, synchronized cardioversion. And we're going to have to keep doing that. And I'll just arm you with that by the time you've exhausted your antiarrhythmics and shocking the patient repetitively, the focus tends to be on trying to dull the sympathetic tone. And you're seeing the results of that by the efficacy of the beta blockade in this patient. You're also seeing how challenging that can be because patients can then get hypotensive requiring pressors, which undoes the beta blockade. And so ultimately, what these patients then get is sedation, and intubation and sedation, often with a powerful sedating medication like propofol. And then also, they can get a selective sympathectomy of their stellate ganglion, which perfuses their ventricles, and they may need that as life-saving surgery. So the simple principles are antiarrhythmics, shock, and management of the sympathetic tone. Now we have to put all that aside because that's being done so ably by Manaswini and her team and ask ourselves, what's the cause here? And Eugene, this is where, after collecting your breath, it's really important to say what kind of ventricular tachycardia this is. And we classify ventricular arrhythmias into two: a monomorphic ventricular tachycardia, which means that the ventricular tachycardia is the exact same morphology, versus polymorphic ventricular tachycardia, where the morphology is changing from beat to beat to beat. How is that distinction helpful? It is fundamental to understanding the underlying cause. Polymorphic ventricular tachycardia is like a generalized seizure. Every part of the brain is equally unhappy. Monomorphic ventricular tachycardia is a focal seizure in a focal part of the heart. In fact, I can tell you exactly where this focus is. Because the precordial leads are all negative, you can then back calculate to figure out based on the direction where this focus is. And you can definitively conclude that this arrhythmia is coming from that location. How does that help? Instead of a substance being the problem, which is diffused throughout the heart, like an electrolyte issue or an overdose of a QTC prolonging medication, Monomorphic ventricular tachycardia implies there is a focal structural abnormality. This is not a diffuse problem. This is not acute diffuse ischemia, which would present as polymorphic VT. This is not medication overdose. This is not Brugada. This is not anything because all those things are diffuse. Every sodium channel in Brugada is unhappy. Every QTC is affected in hypokalemia. So this is a focal structural abnormality. The most common focal structural abnormality is a scar from old ischemia, a prior myocardial infarction, which would be a far-fetched hypothesis in this young man. So now you have to ask yourself, why is this patient have a scar? And you are guided significantly by the fact that he has structural abnormalities on his echo. The prognosis of monomorphic VT is wonderful when you can literally find where it's coming from and ablate it, which you cannot do with polymorphic VT. So now the diagnostic exercise is, why is that part of his heart going crazy? And if we can't control the arrhythmia otherwise, one option we have is to zap that part of his heart should he be more stable. And so your intuition to get a structural evaluation with a cardiac MRI is really, really wise. And I think, as you said, scrutinizing his EKG will help you understand where he might have a structural issue. So in simple terms, as I've said many times before, all of diagnostic medicine comes down to either a substance or a structure. And polymorphic VT is a substance, with the one exception being diffuse ischemia. Monomorphic VT is a structural problem. And now our job is, where is that structural problem and what is the nature of that structural problem? And an EKG, MRI, and of course, the patient's age and demographics will help us a lot. So I've spoken a lot, so maybe we can hand the mic to you unless we need to share what happened next.
Awesome. So the patient was stable for the next 30 minutes, and I will share the EKG. But after 30 minutes, the monitor again started to beep, and the EKG revealed another ventricular tachycardia. So he was cardioverted for the fourth time and was given the second dose of metoprolol 1 milligram and was started on esmolol infusion. It was also mentioned on the chat. After which he did not have any more episodes of VT. And the blood pressure improved to around 112 by 74 mmHg. And this is what the EKG showed.
Wow, Eugene, 2 EKGs in one session, not just one, huh? It's your lucky day today. All right, take it away, my friend.
Could you enlarge it a little bit? Yeah, thank you. Okay, so just by looking at it, you can still see that the heart rate is still fast. It's not yet normal. Um, I can see some in the leads 1, 2, 3. I mean, leads 1 and let me say typically in lead 1, I'm seeing this. So after the KRS complex, you have this downward movement of the weight. So I'm wondering if that's a T wave inversion. Then in lead V1, V2, V3, you have this kind of like rabbit's ear formation of the QRS complex. Um, Also, you can see some T-wave inversions there up to lead V3, also V4, V5. Yeah. Um, yeah, I can't really make, I can't say much about it. So I'll pass the mic to you, Dr.
Oh, I think you
Rabih.
nailed it, my friend. This, yeah, you're absolutely correct. I'll just ask you one question. This patient has a wide QRS. Do you think
Yeah.
their morphology is more inconsistent with a right bundle branch block or a left bundle branch block? What do you think about
Oh, yeah. So this is more like a right
it?
bundle
Exactly right.
branch.
Exactly right. Yeah, you have a RS R prime morphology in V1, and then you have a deep S wave in V6, very consistent with the right bundle branch morphology. And so I think this EKG is very, very helpful because you now have both electrocardiographic EKG and echocardiographic evidence of right-sided involvement, both with the right bundle branch block and the RA and the RV. Um, if you were Eugene to then now take a big stretch, and this is not knowledge that one is expected to know unless they're a cardiologist, but we all should try. So if I were to say you have a young man with uh, right-sided echocardiographic disease and EKG disease, there's a diagnosis that starts to become a working hypothesis that involves disease of the right heart predominantly. Um, and I ask you that question to see what you think because it might influence how we reanalyze this EKG. So input in your mind, young, arrhythmia, and right heart disease. What do you think?
Yeah, I mean, I wish something jumps right off in my brain, but um, arrhythmia, young, right heart disease. Not, I mean, nothing is really
Yeah. Well,
pop.
let me teach you about it. It's not commonly taught about, but its prevalence is actually worldwide and it is being increasingly recognized. The historical term for it was ARVC, arrhythmogenic right ventricular cardiomyopathy. However, increasingly we're realizing that patients actually have biventricular involvement, but the disease is very, very fascinating. It begins first with substructural involvement of the myocardium, where patients have arrhythmias without structural abnormalities, and over the years, the patients develop structural abnormalities over time. The reason I bring that hypothesis up is that there is this EKG finding that is very, very specific but insensitive. And that EKG finding is called an epsilon wave and it refers to a terminal distortion of the QRS at the end of the QRS where there's a positive wave, and you can all Google it, look it up. So I was building some hypotheses based on the echocardiographic findings of right-sided disease in a young man, followed by an EKG with a right bundle branch block. And I'm starting to really want to zoom in on V1 and V2 to see if there's a terminal distortion like this. I'll show you a classic example. Oh, sorry, Mani. Go ahead, Manaswini, please. Maybe you can do it for us. I'll show you a classic example, and then maybe we can scrutinize your EKG. Um, so here we go. This is an epsilon wave right here. So if you don't have a pretest hypothesis, or you're not thinking about it, you would not pay attention to this microscopic thing. It is very insensitive, meaning the vast majority of people don't have it, but it is highly specific, meaning that if this little flick on an EKG is present in the right clinical context, it can be a game changer. So we'll hand the mic to you, Manaswini, for what you have in store. But Eugene, ultimately, what you said is so powerful. We're building a case more and more so for a structural, and in the United States, a structural evaluation is with a cardiac MRI, which can be really definitive in a situation like this. All right, mic to you, Manaswini.
That was amazing. Um, so, the reading of the EKG, I have nothing to add. Um, there was tachycardia of 100 to 110 with first degree AV block with some prolonged PR. And there was marginally wide QRS with the RSR pattern in V1 and V2. And also the first wave was sharp, and then the second wave, the RSR, indicated the epsilon, like Dr. Rabih mentioned. And then there was a small terminally positive deflection in V1 with notching in lead 2 and 3, with some T wave inversions in V2 to V6 and ST depression in V5 to V6. So we did a formal
Can I interrupt,
echo.
Manaswini? I'm so sorry. Do you mind? You were just about. Do you mind zooming in on V1 and V2 for us to try to see if we can see the because it's if you see it in this EKG, which I commend your team for doing so, it really changes the calculus.
So I have another thing to add, Dr.
Oh,
Alvi.
okay, yeah, please, yeah, sorry.
Yeah, no, absolutely not. So I still don't know too much about EKG, but my
Yeah,
attending who
yeah.
diagnosed this patient is also on the VMR today, and a huge shout out
Oh,
to him for supporting
oh,
me by
no
being on it.
way.
And I was working with him during this
Amazing.
time.
Amazing.
Yeah, I'll share
Well,
my
I'm glad we
screen.
got close, Eugene. This would have been very embarrassing otherwise. Oh my gosh.
It's not allowing me to zoom in
I
after
see.
this point.
I see. This is the max you can
Uh,
zoom in, huh? Yeah, I mean, I
um,
think, yeah. Go ahead, Manaswini, please. Take your time, by the way. There's no rush. So this is the most you can zoom in, huh? Well, I think you're muted, but that's okay. Yeah, I mean, that's okay. That's okay. Don't worry about it, Manaswini. We can always this can be a perk of being in the academy where you can share the CKG with us. Oh my gosh. Wow. Yeah, I mean, that's hard to unsee it. Yeah. Yeah, I mean, this will be helpful for everybody to just look up at the same time as you stare at. Maybe you can even take a screenshot of just compare what a typical right bundle branch block looks like. And this is not that. Yeah, I don't know if your attending is here and able to unmute, or I don't even. I'm trying to figure out what mysterious person this is. But yeah, this is a really really cool EKG. Mike to you, my friend.
yeah, it's Dr. Suhas, and I'm not sure if he's in a place to unmute.
I'll pay attention to.
Yes,
Oh,
Dr.
hi,
Manaswini, I'm here.
hi, Dr. Suhas. Thank you for joining us.
Hi, hi, Dr. Rabhi, right? I'm sorry.
Yeah, that's right. Exactly. Wow, you nailed it. Your diagnostician times two.
Thank you. Yeah, Manaswini is presenting the case, and that was like a young boy who had actually walked into ER when what she said initially. He had come telling that he had some palpitations, atypical chest pain, and syncope. So initial diagnosis for us was everything in the world possible. We were even thinking of an MI, but somewhere it went out once the second ECG turns up.
Absolutely incredible case. Thank you for diagnosing the patient in real life. I'll hand the mic to you, Manaswini, to take it away. And thank you, Dr. Suhas, for being here.
Thank you.
So coming back, the team on a formal echo, it showed RA and RV dilatation and RV dysfunction with mild free wall dyskinesia, moderate low pressure TR, RVOT with reduced contractility, no pulmonary regurgitation or pulmonary hypertension, LV globally hypokinetic with moderate systolic dysfunction, and an ejection fraction of 36%, diagnosed by Dr. Suhas, who I'm so grateful for to be here. And then we did a cardiac MRI, and I would like to share the MRI if it's not too much time. Yeah.
Yeah, I don't think we have any MRI interpretation capabilities, so maybe you can narrate it for us, honestly, what you know.
Yeah. Uh, so here we see the RV, and then it has mild outpouchings seen here, and this is the LV. This is the RVOT. So what the MRI, yeah, these were the outpouchings. And what the MRI read was dilated RV and with RVEF of 25% and global hypokinesis, small aneurysmal outpouchings with dyskinesis in the RV wall with diffuse enhancement, and there was thinning and akinesis of the mid-inferolateral segment as well, with transmural enhancement, and there was also diffuse enhancement of the right ventricular wall. So, as Dr. Abi astutely mentioned, the cardiac MRI findings were definitive of biventricular arrhythmogenic cardiomyopathy. And the ARVC has a task force criteria, and this fulfilled the major task force criteria. And this patient was given a beta blocker, and AICD was placed and was sent home, and he's doing much better. So that is the case.
Yeah, honestly, this is a once in a lifetime experience, and I think it's highly under recognized. And you can see why that's the case because the echo and EKG are so subtle, and the MRI is often hard to obtain. And so I really appreciate the opportunity to reflect on this and hopefully help other people spot it. I'd be really curious what your reflections were, but maybe we can get those fresh reflections from Eugene from the perspiration of so many EKGs. What did you take away, Eugene, from this case?
Yeah, very, very interesting case. And I think I'm so happy that Manaswini has presented it. I remember a case that I presented with ventricular tachycardia to Dr. Ravi on the Tuesday VMR. It was an older patient, and that was from an ischemic heart disease. And I haven't really come up, and even if we may have come across young patients with this particular issue in my country, it's quite difficult to go on and on to even get some of these advanced imaging like cardiac MRI to then pin the diagnosis. So ARVC is not something that is just in my short-term memory, like just at the forefront. So I'm excited that I get to see it before I start intern year. And yeah, so it's surprising that I mean, let me say it's unfortunate. Let me put it that way. Unfortunate for a young patient to have this fatty tissue that will not usually do what the myocytes would do. And I'm only wondering if alternatively, if you could do just some CT, if like you don't have the MRI, that's a question I'll ask that could find something or guide you to start thinking about this particular condition. So that's the first. I'm asking for the purposes of low
Yeah.
resource settings.
Yeah.
And when you go on and you do four, I'm also looking at prognosis wise. How was this patient able to have this strong threshold to still receive all these four shocks, and then now he's doing better? So just those are some of the questions I'll ask. Yeah.
Yeah, I think that there's, I encourage all of you to do reflection and reading on this. I'll just impart with you, Eugene, the idea that unfortunately there's no disease modifying treatment. So if you pretended that you did not know what the diagnosis is, you never figured it out, what would be different? And because you can't treat the underlying issue, you probably would offer the patient the same supportive treatment, a beta blocker or an ICD, which he's receiving anyway. The major difference is, of course, there are implications for family members and implications for prognosis. So you're much wiser knowing what he has, what he should expect. But there's also huge implications for future research and development to understand these patients and to begin to try to figure out what they have and how to treat them. But unfortunately, with no current disease modifying therapy, there's less and less urge to get diagnosis because if you're in a low resource setting, you may not use your resources on a situation that wouldn't immediately change your management, understandably so. Uh, and so the quick answer to the question, unfortunately, the CT is insufficient to visualize this issue. An echocardiogram is way better and will catch the disease in more advanced phases. And even honestly, even without the MRI, I think you could come to a tentative diagnosis of ARVC um, based on the epsilon wave and the echo. So that's how it used to be diagnosed before cardiac MRI became more widespread. Manasini, what are your reflections from this incredible journey?
Yeah, it was amazing to be a part of this and learn. So it was insane how that a patient with such a low blood pressure could walk in, and I understand that if someone's undergoing needs cardioversion over and over again, and everything is coming back normal, there must be a structural underlying condition, and ARVC may be asymptomatic for decades, and I think it's really important to diagnose it because it leads to sudden cardiac death. And also that, like you mentioned, the genes, the desmoglein, desmoplekin, and so on, like it's really important for to send these, but um, and also put the patient on Holter monitoring and so on. But it's important to for the patient and also for the family members in the long term. But that will be done, and I learned that it's an autosomal dominant, but there are also some autosomal recessive variants like Naxos and something called Carvajal syndrome and so on. Yeah, so that was really cool, and yeah, I hope if something like this arises, then we all could immediately catch it. Yeah.
If anyone will, it'll be you, my friend. Thank you so much for such an incredible, and the way, you allowed us to reflect on hypotension first, on arrhythmias, on ventricular arrhythmias, on monomorphic ventricular arrhythmias. And so the way you outlined this case is a masterstroke. Really is. And the fact that you concealed the diagnostic epsilon wave until the very end shows how you know its value and how necessary it is. Amazing. All right, Sakith. I think we have a lot of learning. I'll hand the mic to you to see what you'd like to emphasize.
Yeah, thanks a lot for the incredible discussion and teaching, Eugene and Dr. Rabi. So we started off with a framework to approach hypotension. So we can think of it as all of hypotension being a focal problem in a bad location, like a PE or a pericardial tamponade, or a focal problem that secondarily generalizes, like a pneumonia in the lung that causes a septic shock. And then we also learned about the approach to wide complex tachycardia, which is usually either a focus of abnormal activity in the ventricles, i.e., there's no impulse being transmitted via the His-Purkinje system, or the His-Purkinje system itself is unhealthy, which is extremely unlikely in a young patient, as we saw in our case. And then we also learned some management pearls on how to fix an arrhythmia. If you see a patient who's pulseless from an arrhythmia, don't think about anything else. Immediately go and perform an unsynchronized shock. If a person is not pulseless but also not stable, think about a synchronized cardioversion. And if a person is stable from the arrhythmia, then you can think about medications. And then we also learned about the empirical treatment of VT. And so the three pillars that you have to think of are antiarrhythmics, shock, and modulation of the sympathetic tone. We also briefly learned about the classification of ventricular tachycardia, two main buckets, which are monomorphic and polymorphic. Monomorphic is analogous to a focal seizure. Think about a focal structural abnormality, like we saw in our case, or polymorphic is analogous to a generalized seizure. Think about electrolytes or QT prolonging meds. And in the end, we saw that this patient was diagnosed with ARVC, and a highly specific feature that you can see on the EKG of patients with ARVC is an epsilon wave. Thank you so much, Aaron, for describing, and a shout out to Manaswini and also to Dr. Suhas for joining the VMR.
I distinctly remember when Saket did his first teaching points, and I would message afterwards, and he was like, "Oh, this doesn't feel good. I'm so nervous." And we came up with a plan of instead of hiding from it, attacking it, and it's unreal to see the results. And they're on for all of you to watch what can happen with dedicated practice. And Saket, that the crystallization of such a complex case in 2.5 minutes with flawless clarity. There's nothing that you said that wasn't exactly on point. Is absolutely unreal and a testament to the hard work that you've put in. And I hope it inspires other people to do the same. Really, really impressive job for all of you. Aaron, you will type your notes if very efficiently and effectively with how quickly you kept out this case. Manaswini, if you can tell a story like this, you know medicine like no other. And the same for you, Eugene. Anyone who survives 2 EKGs and reads them accurately is doing a great job. So thank you all. It was a real treat to spend this hour with you. And I wish all of you some wonderful news tomorrow morning. All right. Bye.